Thank you very much, Paul. What we're going to do now, so we were supposed to have Dr. Tedros, who had kindly accepted our invitation. Unfortunately, the WHO is taking more time than expected, and the Ebola outbreak as well is taking a lot of its time. We specifically wanted to have Dr. Tedros because to us, he really represents what the changes should be about. He's a scholar, former diplomat at the head of the UN agencies. He's pushing for UHC and equity, and this is exactly what this commission is about. So we have thanked Dr. Tedros for accepting our invitation, and of course we fully understand what is going on and the other constraints. To dive into the report, we propose to organize two panels. The first one is with the commissioners of the next gen of this commission, to try to dive into more details on some of the key issues, and I invite our panelists to join me on stage. Ostan. The second, after the break, we have a break, and then we're going to open to a Q&A session. So we would like to have your feedback and your comments or questions you might have to the panelists. Then we're going to have a break, a coffee break. And then after the break, we will organize a second panel where we're going to have external people we have specifically chosen for this panel, who are going to give us their views on the recommendations we have made. So to join us today, we've got 4 panelists. I'm going to start from the end with Dr. Ossan Bahatab. Ossan is a next-gen researcher from Yemen, living currently in Italy, and used to work at Crimedim, a research center in Italy, and now working with the Geneva Center of Humanitarian Studies in Geneva. And we're involved together on reshaping the national health strategy of Yemen with the Ministry of Health and WHO. We have Dr. Aoula Abara, who is a senior clinical lecturer at Imperial College in London, and an infectious disease advisor as well to Médecins Sans Frontières. Dr. Esperanza Martinez. Esperanza is a professor and head of health and human security at the Australian National University and co-chair of this commission. And Professor David Cantor, who is a director of the Refugee Law Initiative at the School of Advanced Studies at the University of London. I'm going to sit down with you. We have enough microphones, right? I take it. So I'm going to start. Oops. It's on. Sorry. So I'm going to start with David. Weak, Paul just said, weak accountability, impunity persist, and we have seen on the screen, and you're going to see on the report the statistics that we have from Insecurity Insight and as well from WHO. And of course, and there are many humanitarian practitioners in the room. They are the ones who actually, the response is very much damaged by the targeting of the staff and departments. And so David, it has been a privilege to work with you because we learned a lot as professionals. To have a law expert in the room, and you were accompanied with a few other colleagues, has been tremendously useful for us to reshape or rethink or re-question whether or not international law is appropriate. So one of the key questions we had, and you have been challenged so many times by us, do we need to reform this international law? And if yes, what are the risks? And if not, can you tell us why?
Many thanks indeed, Carl, and good morning to you all. I'd like to start just by acknowledging the immense pleasure and privilege it's been to work with all of the experts from across a range of areas on this commission, and particularly to acknowledge the next generation researcher, Malavika Rao, who together with Esperanza and myself led the International Law Working Group of the Commission. On your question about whether the law is sufficient or not, I think we have to take as our starting point, and sometimes this is forgotten, that international law is a creation of states. And sometimes I have to pinch myself to remember that despite that fact, we actually have a relatively robust set of laws in existence. We can't take those things for granted. And I think implicit in the question about whether reform is needed is a question about whether now would be a suitable time for reform. And I think the view of the Commission was fairly clear that efforts at reform at the present time would not be taking place in an auspicious moment, and that actually where we are now is really thinking about a line in the sand, defending what we have so far. We also think reform of international law on the protection of civilians and health at the moment isn't presently required. And the reason for that is because the rules are strong on this issue. There are a range of different international legal frameworks that intersect with one another to reinforce the protection that's available to the right for health in conflict. We're thinking here, of course, not only about IHL, also about human rights law, refugee law, frameworks on IDP protection, amongst others. And of course, the rules of those frameworks are fairly far-reaching in their extent as well. So they not only respond to the risks of armed conflicts, they also respond to the risks posed by climate-related hazards that intersect with conflict-related risks in countries that are affected by conflict. Nonetheless, there's one key issue, I think, in terms of the law itself, and that is that the interpretation or application of those legal rules is sometimes unduly narrow. Now, I don't think that this is the case generally in relation to absolute rules that are contained about the right to health. So here we're thinking about things like the prohibition on inhumane treatment, the prohibition on starvation as a method of warfare, prohibition on attacks targeting civilians and healthcare workers, for example. Nonetheless, there are a set of rules where the humanitarian considerations in the context of war are balanced up against military considerations. And it's here, in this balancing exercise, where perhaps we might think more constructively. An example of those rules would be the rules around whether, if launching an attack against a military objective, that attack is permitted where it may cause incidental harm to civilians or civilian infrastructure. So the rules there are clearly about balancing humanitarian and military issues. And I think that the danger in applying those rules is that one takes account only of direct immediate harms on the humanitarian side of the equation and loses sight of the cascading long-term population impacts in terms of civilian health. Now, one of the main recommendations of the Commission is to continue supporting a so-called full protection of civilians approach, which advocates for looking at the broader public health effects of those sorts of attacks and weighing those in when one is balancing up those humanitarian and military considerations. So that's certainly one area where we think that there could be a sea change in the degree of state support for that, although many states, or a good number of states across the world, integrate that approach in one way or another in their military rules. Nonetheless, I think behind that, there's a bigger issue, and I guess we'll come on to this in a moment, which is that of the basic rules themselves not being respected in practice. And of course, we can see evidence of that in the violations that are documented and which were mentioned by Paul and others in contemporary conflicts across the world, not only targeting civilians, but also targeting health workers and in fact, health infrastructure as well.
Thank you very much, David. So I met a few colleagues from Syria and a few people who have worked in Gaza as well. They all come back. I've heard that a few times that they do not trust anymore international law, and you're telling us they should be protected by law. So the issue is compliance to law. And one of the key recommendations of the report is about that: how to make sure that actually law is going to be applied So do you really think that compliance can be improved?
Again, I think here there's a real challenge, particularly in the current political context. And I don't think that there are any easy wins or magic solutions to this issue. Nonetheless, if we're thinking broadly about these questions, then one of the key things to realize is that where we're talking about accountability to these legal norms, we're not only talking about courts as a pathway for accountability. There are multiple mechanisms that exist, political, societal, and legal, which are available in order to promote compliance and ensure accountability in relation to those norms. As such, addressing the issue of compliance with the basic rules for the protection of civilians in armed conflicts requires coordinated and sustained action by a range of different actors, including states, international organizations, NGOs, and affected communities themselves, in order to push forward the issue politically. And I think that there are some key operational pathways that the report identifies where there are real prospects of practical actions making a difference, especially against the background of a transformed or reformed system, as the broader report recommends. So if you don't mind, I'd like to just talk through a couple of the recommendations made by the Commission in this regard. The first of these, in terms of inverting the power, is putting at the very heart of thinking about civilian protection and the right to health, self-protection strategies by affected communities themselves, and a key role of external actors, whether they be governmental, international, or international NGO, is thinking about where they can appropriately support those kinds of self-protection and community-led engagement strategies in order to improve the lot of civilians and their access to health in situations of armed conflict. And that can take a variety of forms, and that may very well include complementary action, dialogues with weapons bearers, as already happened, in order to ensure that communities have appropriate support for negotiating access to healthcare, for negotiating respect for basic rules of IHL and other rules of international law. So that really, I think, has to be the centre. Where trust is absent there, the Commission identifies a range of other broader political, diplomatic, cultural, and economic levers that might be pulled by external actors in order to try and promote respect for IHL, where that kind of community level trust may be eroded. So moving out, if you like, beyond that initial concentric circle to think then about governments, well, there are clearly domestic mechanisms that governments can and should strengthen in order to protect civilian health. And the report makes a number of recommendations in that regard. One of those is to mainstream leadership on health issues across a range of sectors, including not only health, of course, but defense as well, integrating within military rules of engagement, civilian rules for protection and care for medical staff, and also setting up systems to track and provide effective remedies where civilian harm takes place, and particularly thinking about the health context there. Moving out, if you like, to the next concentric circle, then we can think also about accountability tools at the international level. And really, I think the key message here is that these need to be applied consistently. So it's not enough to have occasional diplomatic démarches on one or other conflict or issue, but rather what's needed is sustained protection diplomacy at the capital level, continuous humanitarian engagement in affected localities. And this, we believe, could be supported by a standing global health protection alliance, including, as Paul mentioned earlier, not just interested states, but also international organizations, NGOs, and representatives from affected communities as well. And the role of that alliance should precisely be to coordinate both pressure and incentives to promote compliance with the basic rules of the law. And that, of course, could feed into processes like the UN Security Council follow-up on Resolution 2286. Last of all, the Commission points to something that I mentioned briefly earlier, and that is the importance of the full protection of civilians approach, and really pushing that forward and taking this crisis as an opportunity to try and bring on board state and other interest in this approach to the application of IHL, and perhaps even think constructively about particular ways in which political momentum could be gathered around the health issue there, and of course support for broader political initiatives that already exist, led by the ICRC and others, to upstep political commitment for respect for IHL. So ultimately here, what we're really looking for is that protection in this area needs to be a combination of upscaled political will. There needs to be consistent and sustained action on this, and there needs to be accountability. The outcomes should be measurable and clear, and here we're talking precisely about reduced attacks on healthcare, the continuance of essential services during armed conflict, and of course, a vast reduction in the absurd level of civilian lives currently being lost. Thank you.
Thank you very much. Thank you very much, David. So we have, this journey has been incredible because we started with a broad analysis of the law, and at the end, with this working group, you have managed to really design some concrete recommendations, which was quite a challenge at the start, and then at the end, we really have some key strategic directions. Another piece of work that has been very important and very innovative, I think, is about looking at or questioning the humanitarian principles, Esperanza. And in a way, these humanitarian principles have been, for the last few decades, our foundations. And suddenly this commission started to question whether or not they were appropriate. One of the key angles was about looking at, one of the key recommendations was about how to shift power. And we realized that a lot of local actors in the system were excluded from the system because of the humanitarian principles. So can you tell us, why do you think it was important to revisit the humanitarian principles?
Thank you very much. And I'm a medical doctor, so really working with lawyers on this chapter was an absolutely fascinating journey. And I want to, before answering the humanitarian principles, I really want to compliment what David has said, and is how do we use the alliance that is being proposed to move from condemnation to actual accountability, legal accountability, social accountability, in a way that attacks on healthcare actually have consequences, real and tangible consequences. So it's a call for all of us here to see how we play our part and unlock the situation in which today another attack in another hospital doesn't even make the news anymore. We need to move away from that. Why do we look at the humanitarian principles? And the reason is that the operating environment today is vastly different to the operating environment we have when the principles, the norms, and the rules that we follow were first designed or first evolved. We have, as we have heard already, and all of you know, we have an environment where crises are protracted, where armed conflict lasts for decades in many areas of the world, where there is fragmentation of armed actors, state and non-state armed actors, where we have a politicization of financing, but we also have a polarization of political discourse that really undermines human dignity and human rights. And we also have, as Paul demonstrated in the graphs, an increased number, the highest record of attacks on healthcare. And the demands on the humanitarian sector, a humanitarian sector that is requested to do more with less. So the question here was not, do the humanitarian principles matter? The question is, can we apply them effectively in the current environment? And that required an examination of the 4 core principles. And based on this, we came on the report basically proposes 3 key points. The first one is reaffirming that impartiality and humanity are non-negotiable core principles. They are not only at the basics of what humanitarian action is, which is basically all our actions are oriented to protect lives, to reduce suffering, and to deliver care based on need alone. So that's at the core tenet. And humanity and impartiality make that possible. And the other aspect is that these 2 principles are underlined and reflected both in the Geneva Conventions and the additional protocols. So they are at the core of international humanitarian law. If we look at today's fragmented world, and not only the polarization of discourse, but also the fact that we often don't acknowledge the other, that we have wars that have been fought at the distance with great suffering, we also really wanted to emphasize the need to speak more about humanity and our need to address human suffering wherever it is taking place. The second point we make is that, and you already mentioned this, Paul, at the beginning, is that we reaffirm that neutrality and independence are operational tools that are important for many humanitarian actors to be able to be accepted and to be able to have access in highly contested environments. However, they are not ends in themselves. They are contextual, and not every humanitarian actor should be required to uphold independence and neutrality to be supported. And I think it's very important here to clarify what they mean, because they are often very confused. So neutrality means not taking sides in hostilities and not engaging in controversies of political, religious, or ideological nature in relation to that specific conflict. And independence means humanitarian action must remain autonomous from political, military, or external influences. For some organizations like the ICRC, visiting detainees, crossing front lines, delivering care in very highly contested environments, these two principles are core. They are non-negotiable as well. But what we found during the commission is that both neutrality and impartiality are very often used to sideline and not to support local actors, with the excuse that they are not legitimate actors because they are too close to the communities. And that is what we want basically to highlight here, that needs to change. So we consider not only that we need to ratify or to confirm that neutrality and impartiality are that neutrality and independence are context dependent, but also to ratify and to confirm that neutrality is not required under international law for protection. What is required is impartiality. So a local actor might not be neutral, but might be impartial. And we in the humanitarian sector must support those responses. And I would like to give you an example here. A few months ago, I was having meetings virtual with medics from Myanmar. And they clearly say, we sit in opposition to the military junta. However, we treat everyone who requires help. And those very often are members of the military junta or supporters of the military junta. But it's our duty to treat them. If that is a consistent approach, that action is protected under humanitarian law because it's impartial, although the actors are not neutral themselves. So we really thought that was important to clarify in this context, because that's the reality we live today, and not only in Myanmar. That's the reality we are facing in Gaza, the reality we see in Ukraine, in Lebanon today, across the world. We are seeing attacks on health facilities because they are not neutral. And I think that distinction is actually quite important.
Thank you very much. And then, so we added 3 humanitarian principles: do no harm, solidarity, and accountability. So can you explain why and what do they mean?
So we look at what other values and principles humanitarian actors were using and have been using for years. Many of you have, besides these core principles, have many others that you have been using. Do no harm, first of all, aims at avoiding humanitarian action and intentionally deepening inequities, creating harm, sidelining humanitarian actors, or as well deepening inequities when you actually provide or have access only to a certain group, but not to another. Do no harm, and I'm just going to give you one example, should be at the core of planning and the deployment, for example, of digital technologies in situations of armed conflict and in humanitarian crisis. That should be the primary goal. Do not to create harm to the populations that are where those technologies are deployed. But do no harm as well sets a benchmark for accountability to affected population, because it's actually something that is measurable, that we can actually use to see whether humanitarian action contributed to the dignity and upholding the safety of communities or not.
So it goes beyond the medical term. Right?
Yes, it do no harm is used very much in the medical field, but it goes beyond that. It's applicable in the implementation, in the planning, in the financing of humanitarian aid. So solidarity, which is the way we describe solidarity in the Commission, it means standing with communities, recognizing that communities are not passive recipients of aid, but communities and local actors are actually decision makers and should be partners. And that's the element of solidarity, and is central to the Commission's proposal to invert the power, which is the decision making should be with those who are close to the crisis, because they are the ones closer to the solutions as well. And the last one is accountability. And accountability here is not on, and we have been over the past few years, we talk about accountability in relation to financing, reporting to donors, and more and more about accountability to affected populations. But what we found throughout the Commission is that the application of AAP, or this accountability to affected populations, is weak in many different areas of the world and in many crises. And beyond that, we consider that accountability is not only accountability to affected populations, but it's also consequences for pay protection and for exclusion of certain groups from humanitarian action, consequences for attacks on healthcare, falls under this broader accountability umbrella, and consequences for preventable system collapse. The fact that we unintentionally very often create parallel systems that actually undermine the very systems that communities require for their dignity, their survival, and their health. So those are basically why these three, it was very difficult to really come to three contemporary principles that we could propose at the same level as humanity as impartiality. But we do consider that within this comprehensive framework, they actually enable the possibility to move forward.
Thank you very much. And I do think that these principles really reflect the key recommendations of this report. There's a beautiful alignment on the inverted power, but as well accountability as a cross-cutting issue throughout the report.
And impunity, a key one as well.
We talked about law, we talked about humanitarian principles, and we're going to, it is a Lancet commission, so it's about the health as well. So we want to change the system, and as Paul really explained very well, that health workers can only work in a system that functions and that protects them. That's very important. But of course, we analyzed a lot of data on the consequences of health, of conflicts and displacement on the health and well-being of populations. Ayoola, if you want to try to synthesize a little bit the evidence that we collected.
Cool. So thank you very much. Of course, this is a health commission, and all the broader determinants of health are fundamental to how we see health in the field. And that's why we did step back and talk about these important principles. But through our work and through our research and through our discussions, we really wanted to embed the Commission in what our communities are facing very directly through the face of conflict. And I really want to stress here something Paul picked up on. When we talk about conflict, we're talking about different typologies of conflict, different impacts, and also different intersectional vulnerabilities on some of the most marginalized people who are suffering tremendously in ways I don't think we can ever imagine. But beyond this, and increasingly when I work on conflict, I really struggle, because actually we are definitely in the age of multi-crises. Climate overlays on top of natural hazards, and I won't say natural disasters because that's incorrect. And we saw this in the southeast of Turkey, the northwest of Syria, where after tremendous conflict and suffering, on top of that, we had a devastating earthquake. And on top of that, we're seeing the impacts of water and sanitation on health and its destruction. And of course, on the massive funding cuts that we see very directly affecting populations and all the international organizations that have been doing great work, but also the local organizations that are also suffering the impacts of these funding cuts. So what does that mean? So very broadly, and I'll try and be brief, we see the direct impacts. These are the visible impacts that we see. We just need to look at any news report on Gaza, on Lebanon, on South Sudan to see children with traumatic limb injuries. They are going to face a lifetime of devastation, of social compromise, educational compromise, potentially, and they will never get the care that they deserve to allow them to live the best life that they can, having already suffered something so early in their lives. But it goes beyond the injuries. What we are seeing is a crisis of sexual and gender-based violence. I have to engage with this topic because I engage with countries such as Ethiopia, South Sudan, Sudan, DRC. The impunity and the extent of this crisis, predominantly for women and girls, but we mustn't forget men and boys here, because what we are seeing is a shift and a weaponization of something that devastates humans at a physical level, at an emotional level, at a psychosocial level, onwards, and at a community level. And this is something that also is occurring without accountability and also occurring with impunity. To quote data from Médecins Sans Frontières, Epicentre, they looked at 2024 data and they interviewed women in the DRC in North Kivu. And they found that 1 in 10 women in the last 5 months had experienced an assault. And I say women, but actually it was adolescent girls that were the most at risk among this population. And this is devastating, but also, and we haven't spoken so much, I think, about the politicization of this fear, but being able to respond, even for MSF, to respond to the needs of these women is becoming, and these women and girls is becoming increasingly difficult. All of this comes with a morbidity and a mortality, but also a mental health and psychosocial toll that goes beyond anything that we can imagine. In Gaza, in Lebanon, what we hear of the devastating tolls, the trauma that I think will be generational, and we know this from previous studies of the Holocaust and from the suffering of Palestinians previously as well. This is not a one-off, this is something that we will see into generations. And of course, in a setting which is unstable, which is acute, I often hear people talk about post-traumatic stress, but actually there's nothing post in the stress and the trauma that the populations are currently experiencing. I do want to highlight here, beyond the communities, beyond the populations, many of our colleagues and health workers, they themselves are within the communities affected by attacks on healthcare and facing the conflict, but they're also trying to respond. And I think we as a community must also be mindful of that and work with them to that effect. Beyond the direct toll, there's an indirect toll. And this is perhaps less visible. This can take multiple different ways. We've heard about attacks. Beyond that, there's attacks on infrastructure, water, sanitation, medical schools, universities, roads, everything that goes alongside it. This interrupts healthcare access. It interrupts, and I'm an infectious diseases physician, our ability to implement public health interventions that are fundamental. Something as simple or as complicated as vaccine preventable diseases, or making sure that we do not have zero-dose children. And of course, once again, I must allude to the funding cuts affecting UNICEF, Gavi, and others here. Data suggests that actually the indirect toll can be greater in terms of morbidity and mortality on these populations. I saw a quote that said the median death rate is much higher in terms of the indirect. I think it can even be up to 70% and upwards. And this is perhaps less visible. I can say that my work on Syria, we estimate between 600,000 and 1 million people have been killed directly in the conflict. But you can only imagine many more thousands, if not hundreds of thousands and more have been deeply affected even beyond that. I do want to highlight here people who are the most marginalized, and I've mentioned gender. I think it also goes down to social status, education, disability, onwards. But we must highlight here people who are internally displaced within country borders, and they can be among the most vulnerable for a whole variety of security, political, social, and other reasons. And of course, among them, the direct toll on their health, their ability to access healthcare can also be severely compromised, perhaps even more so than the host populations. I'll end by exploring a little bit about the infectious diseases impact, because I think this is important, and in certain contexts, even something as simple, as complicated as diarrheal infection can cause a mortality of upwards of 40% in an acute crisis. In terms of looking at the association between infectious diseases and conflict, I would argue we're still nascent, but there is data emerging, trying to tie in not just conflict, and I'm struggling because I would say this one word doesn't capture all the different typologies, the acuteness, the intensities of conflict, but putting numbers to the impact that conflict can have on certain infectious diseases. So we've done some work looking at leishmaniasis, and we showed that the higher conflict intensity in a country was associated with a much higher incidence of leishmaniasis. And of course, there's massive underreporting of leishmaniasis to the WHO. We can look at cholera. Médecins Sans Frontières and other humanitarian organizations are dealing with some of the worst cholera outbreaks anywhere around the world. And we mustn't forget, in Yemen, a country affected deeply by conflict, between 2017 and 2020, there were more than 2.5 million cases of cholera and a few thousand deaths at that time. And you can imagine that can also overwhelm the system. And this is something that's entirely preventable through the determinants of health, through adequate water and sanitation, even through oral cholera vaccine, which is not always available in the timely manner that it must be for the populations. We're also inundated with many of the vaccine preventable diseases, diphtheria being an important one and also a neglected one. And once again, we speak of global solidarity, and for me, this is very important. And I will never not think about the fact that if diphtheria were affecting many of our populations in the global north, we would absolutely have better treatments, better modalities to respond, but also more availability of diphtheria antitoxin at the time it's required. And we know that there are global shortages, but that's coming and going. But we face severe shortages, which I have no doubt led to the loss of lives of children in settings where it should never have happened. And if I may, one of the things that I do a lot of is malaria. And actually, if you start looking at the data on malaria, 66% of malaria endemic countries are affected by conflict, and not a single fragile or conflict affected country, and that's an imperfect term in itself, has eliminated malaria. And again, with the funding cuts, with the impacts of climate change, we are losing control of malaria when just a short time ago we were talking about elimination, and we're having difficult discussions around vector control, bed net distributions, and malaria vaccination. But actually, we should be preventing it and working towards elimination for the sake of our populations. I'd also like to highlight here antimicrobial resistance in the settings of conflict. So I've spoken about the toll of the injuries, of the crash injuries, the devastating multiple injuries we often see among populations. And I'll speak to Gaza here. So MSF data pre-conflict showed pre-current conflict, I have to say, showed alarmingly high rates of antimicrobial resistance. So the rates of carbapenem-resistant Enterobacteriaceae among gram-negatives were significant even then, and also of ESBLs. Almost all microbiology laboratories in Gaza have now been destroyed, and we know that there's widespread destruction of the health system. Access to healthcare, logistics and supply, the ability to have any sort of meaningful infection control, the contamination of water, and the ability of populations to have the needs met, appropriate surgeries, and of course, we're putting metalwork into vulnerable children who are also malnourished, which ties into this conversation of infection and antimicrobial resistance. Okay. So globally, this is a crisis, but in conflict settings, it's that much more of a crisis, and that's much more challenging to address. And lastly, if I may, for me, and I think for many of us in this room, it is no surprise that the Bundibugyo Ebola virus has reared its head in North Kivu. This is a setting of profound conflict, insecurity, politicization. We think there's over 400 cases, and many of them at this stage are suspected. But I have no doubt that this crisis was, these cases were latent even before the first cases were destroyed. And actually, the ability to respond as a humanitarian community in this space is highly compromised when actually there are things that we can do in terms of operational research, in terms of evidence, in terms of being able to respond, in terms of diagnostics to this population. But that's made all the more challenging because of the severe conflict insecurity in somewhere like North Kivu.
Thank you very much, Aula. And I mean, this working on this chapter, Aula, we worked together with a few of the members. We learned a lot by trying to synthesize the evidence that we have. We have also identified quite a few gaps, and I think in the next few years, that's going to be probably our priority. And I know you've been involved on a consortium researching, investigating MMR in conflict settings. The great strength of having you on board is not only you're a fantastic researcher, but as well, you spend a lot of time in different settings, in different crises. And this commission has actually developed quite some key recommendations to make the response more effective. If you can explain that a little bit.
No, absolutely. This commission has had a lot of profound discussions over the last 2.5 years. And I have to say, for me, it's been a privilege to listen to the different perspectives, but also to listen to some of the things that keep coming up over and over again. And some of those Paul alluded to on that initial slide. One of the things that came up over and over is something fundamental and important. It's this issue of localization. What does that mean in terms of humanitarian response? And those of you who've been doing this a lot longer than I will know about the grand bargain, about the promises made over the last few years, but sadly also their abject failure. So we had a lot of discussion as to why they failed. What is it that we need to do beyond the obvious? And what are the discussions that we need to have with local communities? So much of my work over the last 15 years has been on Syria, and we've got some of our Syrian colleagues who worked in the local response at times of incredible and acute and devastating conflict. And listening to them, understanding what the humanitarian system looks like in their eyes. And actually the failure of localization in a situation where it would have been very, very well suited, and actually, quite frankly, probably more effective, more efficient, more in line with what the community needs in being able to respond in some of the most difficult settings. I do want to highlight here something that's also very important, and Esperanza spoke of Myanmar. There are certain settings around the world that are so dangerous that many international organizations cannot, because of risk, because of other factors, place their international staff. And again, this is very sad because there is a discrepancy between international local staff and how they're seen and treated. But what that means in many of these settings is they end up working almost through as a conduit through some of the local humanitarian organizations that bear the risk. And actually in Gaza, I think it's now more than 1,700 humanitarian workers have been killed, and by far the majority are local from Gaza. In Syria, we've lost more than 900 healthcare workers, all of them health and humanitarian workers inside Syria, so not internationals or people like me who are dual nationals. So what does this mean? We need localization, we need to shift the power, we need to fix the money and everything that goes alongside. But for me, and I approach this with open ears because I got the privilege of listening to some of my colleagues discuss something so fundamental and something that we always have to tie in with this discussion of localization. And I do want to quote Yetza, who's one of the other commissioners here, because she captured this better than I think any one of us could do. She said, when we talk about localization, we must go beyond the binaries. So it's not decolonization or localization, but these are two things that go hand in hand. Because if you have localization without decolonization, all you're doing is moving some of your headquarter staff to a local, and again, this is an imperfect term, global south country or context. But that's not true localization. And in fact, you're probably entrenching inequities, you're probably fragmenting local systems more than you are doing anything positive. And so the decolonization element and this decolonization of our humanitarian practices, our humanitarian thought, And actually in the Commission, there's some brilliant pieces around the history of humanitarianism and how it's very much a sort of a Western style of thinking, which is why the concept of neutrality has come in. Because actually, when you speak to some of our colleagues in the field, some of my Syrian colleagues, it was natural that you wouldn't be neutral, because we shouldn't be neutral when we see injustice in front of us. We must be impartial, and all of them very clearly stated, we are impartial, we will treat anyone, but how can we be neutral when we're seeing children facing chemical weapons and attacks? So what is it we're looking for when we're talking about decolonization and localization? And actually part of it is the discussion on funding. There's another part that's also around the sort of ethos, the discussions, the terminology that we use. What we're looking for is being embedded with local communities, being respectful and empowering of local expertise. So not for someone even like me who is Syrian, but of course a dual national, coming in and saying, I know better than you what you are seeing daily in your lives with the communities that you're serving, and actually the multiple challenges that you face that I don't think many of us could imagine in the face of our work. What we're looking for is balanced power and resource allocation that is meaningful and very direct to the local organizations. And this becomes important in terms of the overheads that are lost, but also the ability to have a system that's agile, that's adaptive, that's responsive. I do want to reflect here about what happened in the earthquakes in northwest Syria. Because of the role of donors and funding streams, and of course this is a system that we work in, there was almost a dictation for the local organizations of what they could and couldn't spend money on in a very acute, very complicated crisis. And actually remember here, the Syria response to northwest Syria was based in Gaziantep in Turkey, that was itself paralyzed and devastated by the conflict. And actually, there were no offices in the northwest of Syria where there are very capable people who should be able to respond. And what we saw was, and remember in those first days, there was a tremendous loss of life because of the widespread politicization of humanitarian responses and the need for international organizations to work with heads of states. And that's why we've had these discussions about who is a legitimate actor, because actually the former Syrian regime was not a legitimate actor in the northwest of Syria at this time. So we're looking to turn many of these concepts on their head. We want sustained, legitimate interventions. We want meaningful global, local solidarity that isn't differential. I think it's very clear for us that actually there's global solidarity to certain contexts that doesn't exist for others. South Sudan has faced tremendous attacks on healthcare, tremendous suffering, as has Sudan, as has Darfur, and there's been devastating massacres, devastating impacts on the populations there. But we've definitely not seen the same global solidarity as we have seen for some of the other contexts that we're aware of. And so ultimately what we want through localization and decolonization are local systems that are resilient and responsive and able to respond to the local populations that are most in need. And actually they are probably closest to the ground to be able to do that. And hopefully that will lead to better aid effectiveness, better legitimacy, better processes that can allow this response.
Thank you very much, Awula. And I think this has been a very powerful piece of work, and the influence that you had on the Commission was incredible. And as well, I've seen Dr. Munzer as well in the room from Syria as well, who's here. And then all this team has been incredible as well to reshape our thinking. We learned a lot. Thank you very much, Awula. Osan has been a discovery for us, and a beautiful discovery, because suddenly we are working together after the Commission on Yemen. And you have led with Professor Huda at University of Aden this piece of work, qualitative study in Yemen, to try to better understand the perceptions from affected populations and from healthcare professionals. So what did you learn during this study?
Okay, thank you, Carl, and all the commissioner for this opportunity, and the chairs. Before answering your question, I would like to also connect what I have learned from this case study also to my experience as a researcher. So if I will connect this in maybe one word, is the hierarchy. So one of the most repetitive theme that come through the qualitative study, whether from the professional or even from the affected population, was how the risk is always transferred to downward to the local actors, and then to the, as much as you go in a frontline responder, and of course the worst who carries the whole burden is the affected communities, while always the resources, authority, control over the decision making is going upward, sometimes toward the central, but mainly central government or what exists as a legitimate authority, but mainly toward the international actor, and usually the last word usually for the donors. So this is come again and again, and the another maybe theme that always come through these studies was there is a portraying for the affected communities that as a passive recipient. This is or beneficiaries, but usually those who are the first responding to the humanitarian crisis are they are themselves, their community, their families. So we're always talking about the formal humanitarian system and the problem with the humanitarian system. But actually, most of the burden, most of the response is coming from this informal system, which usually these population are all also affected by the crisis themselves. But we don't talk about the resilience, we don't talk about how we can really support these informal systems. Backing again to reflection on my experience also as a researcher in nationally and internationally. I would say also this hierarchy again comes again in the humanitarian research. So local researchers usually are the keys for the international researcher. They always valued for their proximity, for being for their accessibility for the community. But unfortunately, when it's come to intellectual contribution, they always being put down in shaping the research agenda or priorities for research, not listen to what they really think about what needed in terms of research or how this can make an intellectual or knowledge contribution. So probably this always both links, but I again also there is intersectionality that also go beyond the humanitarian research. It's always there in academia, global health research, but when it comes also to humanitarian research, we are working with so many disadvantages that are interacting together, making this also a difficult situation for especially local researcher. So probably what working in this commission give a little bit of hope as well. I think what was I really valued about the commission is that bringing everyone together, that the real and the genuine dialogue across generation, across expertise as well and discipline. And also interacting with not only with your local but also a international commissioner. So I think this is give. I know as someone also working within different spaces, this is not something easy to be done. But I think it also give a hope that this something is possible. I know it's not easy because it's always not really about the individual researcher. It's always embedded in the system. And also working as an international researcher, I understand that sometimes that it's very difficult to make this easy. So, but it also gives us hope.
And now you're working on the providing technical support to the ministry and WHO to develop the national health strategy. Did you pick up some of the recommendations that could be? I mean, after you spent 2.5 years with us, and then did you? I mean, do you think some of the recommendations could be applicable to the work you are currently doing, because you have analyzed the whole health system for Yemen for this work, and I'm just wondering whether some of the recommendations resonate with this context.
Yeah, definitely. I think well, all of them are relevant, of course, because I think what what is important about this recommendation is that it's not only about the technicalities can be different among different contexts, but really when we talk about the system, it is almost the same problem everywhere. And this is not, it's the same case, of course, in Yemen, and probably the power dynamics that I start with it, and the hierarchy is one of the important or critical elements also that appear very clear in Yemen. And I think also working through the strategy, and probably you know how is the dynamic and how we try to move the power from the international, from the donors into the national and local government. It's not easy task, as you know, but we hope that it will work.
Thank you. Thank you very much, Hossan. So we've got a few minutes before the break, and then I would like to open for maybe two or three questions. I've got one here, very a pressing one on the front. Yes. And another one over there. Yes.
Thank you very much.
You introduce yourself.
I'm Mohammed Darwish. I'm wearing now CHH hat. So my question is to Ola, related to the point that she raised related to decolonization and localization. My question is, how, in practice, how can you prevent humanitarian actors from basically changing or using localization as a cost-saving exercise or replacement of decolonization? Thank you.
Okay, thank you. Second one over there. Yes.
My name is George Munya. I'm a former community health worker from Ghana and currently with UNICEF. I first would just like to acknowledge that having attended several international conferences, programs, this is the first one that I feel have done good justice to representing the voice from the front lines and from communities. And for that, I want to say a big thank you to the Commission.
Okay.
The Commission highlighted a lot of things, and I'll share a quick experience and end with a quick question. The first thing is around what does community engagement really mean and what does it look like? As a former community health worker, more often, any community consultation has always been a checkbox exercise. And they're receiving these popular dynamics within the villages I worked, where if any organization or individual comes in and asks, what problems do you have in this community? The question we ask is, what problems do you have money for? Because we are so used to the idea that when you say, the biggest problem we have in this community is water, the individual can say, I'm sorry, I have money for HIV, and they will leave. And so this idea of what is the true meaning of community engagement, and the idea that community engagement should go beyond checkbox, is very important, and it was well highlighted and captured by Paul's presentation. And for that, again, I'm speaking with a lot of emotion because I have seen a lot, and I happen to be on this side where I see the global engagement. And more often, it has always been deeply disturbing, the misrepresentation and the lack of knowledge of realities at the front lines. And to see that today is really very personal.
Thank you very much. Thank you very much.
Thank you.
And a third and last question here from our colleague from UNRWA.
Thank you very much. My name is Seth. I'm from the UNRWA. Thank you really so much. First, Paul and Richard, thank you really so much. Your commission give us power to continue what we are doing on the ground. And but I also promise you, we'll give you power back to you so that we can continue to work address this one. And so work in Gaza is nothing but mission impossible. Everything we do prohibited by political environment. Many partners lack the essential medicines. Many partners lack essential medical supply, but we continue. And the UNRWA alone that conducted 4 million medical consultations last year, which is almost 40% of the entire medical consultation. And in the middle of the darkness of the impunity, and we lost 391 staff in UNRWA and the 20 plus staff for health. And then we were always wondering what we could do. And what I told to myself, we just continue what we're going to do. We recorded what's happened, and we left the judgment of the history, but we want to stay in the right side of the history. And that's what we really want to do. And because I don't want to bend the knees to the people who really mesmerize the world. So, but how we can address the impunity question to David under such context, yeah.
Thank you. Thank you very much. Okay. Aula, yeah, on the first question.
Cool.
Maybe.
So firstly, thank you very much, Mohammed, for a very difficult but fundamental question. I think this goes back to accountability and holding these organizations to account. Over the last few years, perhaps I've developed a cynicism, but maybe a greater understanding of how the humanitarian system works. And I don't think, and we always go back to this, the donors and those who are funding have an awful lot of power. And actually, if they set the agendas both for good or not so good, and maybe they also need to shift at the moment with all the complexities associated with that discussion and what pooled funding looks like and how funding is assigned at the moment. But if donors and funders can hold humanitarian organizations to account. What I didn't speak of is some of the discussions we've had around some of the data, the monitoring and evaluation, which exists, and the NEAR network, I think the START network is another one, where you can have certain indicators that you can follow across time and actually hold both the humanitarian organization and maybe also donors to account to say, but actually this is the shift that's needed. And that's also why we didn't want to just talk about localization here. It needed to be intimately coupled with decolonization so that we don't just pay lip service to something that has had lip service paid for it over the last few years.
Thank you. Thank you very much, Aula. Osan, do you want to take the second question or? Yes, please.
So,
can you answer the second question that we asked, George?
I
didn't hear. Okay, Esperanza. Esperanza can start.
I will touch on the issue of impunity. And we have been asked in the last few days when some of the commission recommendations were shared with very few groups. The question is, how are you tempering ambition with realism? Is this actually going to happen? There are so many problems in the humanitarian sector. We are so busy with reform. There is no money. There is so many humanitarian needs. Is this actually something that can be done? And I think, and the answer has been, in a moment of crisis is where transformations can happen. If you have a status quo, a system that is stable, changing it is extremely difficult. The humanitarian sector as it is today is not sustainable. It's just not going to continue to be possible to do what we used to do forever. And therefore, the opportunity to change is now. And the reason why this commission took, for example, great effort to say, what can local communities do? What can national governments do? What can local authorities do? What can regional bodies do and international agencies? Is because we need to chip in collectively to actually move the needle into action. And what you have mentioned for Gaza, we keep documenting because we want to be on the right side of history. There is a lot about documentation, but there is also on the alliance and the call for a global protection alliance or a protection alliance for health is how we make sure that we have the tools to actually support actors on the ground that are preserving evidence, there are a lot of judges and legal systems and people that are really looking at how can we move this into, for example, prosecution for accountability. And that is something where we can learn from other sectors. There are examples already in the climate space that could actually crossbreed into the health sector. So on impunity, I think my final point is that what the Commission brings and the fact that we didn't look at health only from the health sector, but health as a broader concept, is because the needle will be moved when all sectors actually recognize that this is a cross-sectoral effort, and we need to actually identify levers of change that are local, national, regional, and global, and that involve diplomacy, legal, operational actors, and health systems.
Thank you very much. On these words, we're going to break. There's our team members are around. There's a coffee break served in the hall. They can guide you. We're going to start in half an hour sharp at 11:30. So please be in the room at 25 past. We're going to pass the QR code as well as you have in your room, but as well now you have online. So see you in a few minutes. Thank you very much.